Thank you so much, Stuart. In the next part of the program, we will talk about an initiative that the Sheriff's Association was very much involved in over the last few years relating to alternative transportation for TDOs. Finally, the General Assembly put money in the budget last year with $7 million for the 2 years to start an alternative program. And we have with us here today Gail Paysor, and Gail has her staff with her, and she's going to talk about the rollout of the transportation program. Gail began her work with the Department of Behavioral Health and Developmental Disabilities in February of this year as the coordinator of the new alternative transportation program. Gail, y'all can come on up while I'm doing this. Prior to her position, she worked 25 plus years in various leadership positions in both public and private mental health and developmental services positions in the Commonwealth and at the Northwestern Community Services Board. Gail, thank you for being here with us. We appreciate what you're doing, and we look forward to that partnership on this alternative program.
Good morning. Thank you, John, for having me back again, and thank you to Megan and Susan for helping me with putting PowerPoint and getting everything together. I appreciate it a great deal. Today I'm going to give a fairly rapid overview of the Alternative Transportation Program and where we are in development at this point. You will be invited, if you have not already attended in the far southwest part of the state, to a stakeholder meeting when we roll out in your locality, so stay tuned for that. I'll talk a little bit more in detail about that. The last time I spoke with you all, I think I'd been on the job maybe 2 weeks. Since that time, we now have signed a contract with G4S. It's kind of humorous because the last time I attended this conference, G4S was actually one of the vendors here, and we could not speak with one another at that point. So your previous presentation sort of reminded me of some of that awkwardness in the beginning. I want to introduce a couple of folks, and let me make sure that I have what I need to advance here. Generally, the three of us do this program together. We decided in the interest of time, you're just going to have to listen to me at this point, but I wanted to introduce to you, first of all, Dustin Wilcox. Dustin was hired in June to assist me in the rollout of this implementation statewide. Dustin came after 8 years as a Roanoke County police officer. I think he is a great asset to helping me understand the points and the reference from a law enforcement standpoint that I didn't have, so I think we make a very good team. Then Chris Roberts is the contract manager for G4S in this project. We believe we have hired the right company to do this, and we are very excited about getting it rolled out. Excuse me. Just to remind you that we operate under the Code of Virginia 372810. This guides how we are setting up the program. It does allow for an alternative transportation provider, and that is what we will be governed by and what we use under the code for this. As you all are well aware, there are several points in the ECO-TDO process in which a person can be transported and may need transport. I want to emphasize that we are limited in our budget and resources, so we are confining this to individuals who are under a temporary detention order at this point. We are very well aware that you do much more than just that related to transportation. We hope that if this goes well, that we will have the influence to be able to go back to the General Assembly and expand beyond just the TDO transports. Last fiscal year, the one that ended on June 30th of this year, we had $2.5 million. Most of that first year was spent in the procurement process. We got a contract signed in May. And then in this current fiscal year, we have $4.5 million ongoing. We will have $4.5 million to do this project statewide. So we've been really busy over the last few months, creating infrastructure, creating policies, procedures, purchasing and outfitting vehicles, which you'll see some photos here in a few minutes, but we have a live vehicle fresh off the assembly line outside here. If you get a chance and you haven't seen it yet, please go out and take a look. We have been hiring patient support staff who, that's what we're calling our drivers, and beginning our work in Region 3. So you can see the far southwest in that light blue is the part of the state where we are going to begin this. That is where the pilot project took place. It is where the majority of TDOs from the state are coming from, and it's where individuals are traveling the farthest in order to go to their TDO location. We've had 3 stakeholder meetings, and beginning in July, we had Danville, we've gone to Roanoke, and we've been in Abingdon, Virginia. And we plan to kick off, write this down, October 7th at noon, beginning in Region 3. We will be starting the service at that point. Region 1, which is the central and northern part of the state, we will begin having meetings in December. They are already scheduled. I will be sending out emails within the next 2 weeks related to giving you information if you are in that part of the state. Encourage you, beg you, please attend those stakeholder meetings. We go over a lot of information, and that's where we sort of get down to the nuts and bolts of how we will communicate with one another and how we will work out issues of transfer of custody and that kind of thing. A little bit about G4S. They are a nationally recognized contractor for behavioral health. They have been doing this service in North Carolina about 7 years now, Chris. They are experienced. They haven't done it on the scale that we are doing it here in the state of Virginia, so it is a learning process for both of us. As part of their contract, our expectation is that they will eventually be doing 50% of all TDO transports. Excuse me. We got that figure because in the pilot project, they ended up doing about 41% or more by the end of the project. So we think it's a worthy goal that we can get to. You saw, if you were here, Daniel Herr's presentation yesterday. For the last 3 years, there have been about 25,000 TDOs every year across the state. So this, I'm sorry, that's in my throat. So the expectation is that, water everywhere. The expectation is that they will eventually be doing 12,000 TDO transports for us. Thank you. Excuse me. The other piece of the contract is that the wait time, once they are called to come do a transport, will be 2 hours or less 90% of the time, and we'll talk a little bit more about that further in the presentation about how they will intend to meet that goal. They will be available 24/7. Talking a little bit about patient support staff. So the drivers that are hired to do this will go through about 80 hours, 2 weeks of classroom and on-the-job training. Initially, we had required in the contract that they would go through the 40-hour CIT training. We have since changed that. After delving into it, we realized that a number of pieces of that CIT training were not as relevant. In addition, getting a seat at the table in a timely manner for our staff in order to get them up and running, it just wasn't going to, the logistics of that, it just wasn't going to work particularly well. So we took a step back, looked at what were the essential elements that they would need. So they will be doing a 24-hour course, learning about an introduction to individuals with mental health and crisis and some other population and special population characteristics of the individuals that they will be transporting. So we have changed that piece. In addition, they have to be CPR, first aid certified. They are certified in CPI, which is a de-escalation technique, and they will be certified in mental health first aid. So this is a photograph of the uniform. They will be wearing a soft uniform. They are not armed, and they will not be using restraints. Chris, you don't have yours on today. I can't let you model.
You don't want to see me.
These are the vehicles we are using. This has been an evolution from the learning points that G4S brought to us. They began service in North Carolina using just a regular sedan. They then went to vans. They had to retrofit those vans with heating and cooling because of the partitions that are between the driver and the patient. It was a very expensive endeavor until they discovered the Dodge Durangos. These allow for the patient to be comfortable in a climate-controlled area without having to retrofit them with heating and air. They are fitted with a number of safety features. There is a barrier between the driver and the patient. In addition, there's a barrier to the back so the patient can't access the back trunk area. And if you see, you can probably see in the next one better, there is a partition between the two back seats. That is so that two patients can be transported safely at the same time. In addition, they are retrofitted with this plastic molded seat. This is for a number of reasons. One is so that it can't be torn out and torn up. In addition, it is easy to clean should that be needed. There are cameras on both the individual and on the driver at all times. Per the contract, G4S is required to keep footage for 2 months in case we need to do quality reviews, or when we do quality reviews, or in case we need to debrief if there is a significant incident. In the back, in the trunk that is secure and patient is unable to access, they keep the patient's belongings in a lockbox. They check that out when they do the transfer of custody. The patient's belongings get placed in here and locked and sealed until they arrive at the TDO location. In addition, there's first aid and those kinds of things in the back. Communication center. So one of the beauties of this is that there will be centralized dispatch so that we can use the efficiency that is something you all don't have the luxury of when you're crisscrossing the state and your peers are bringing someone to Southwest while your Southwest peers, are bringing them across the state. We will have centralized dispatch 24/7. One of the ways that we intend for them to get to the patients in a timely manner is to use this hub and spoke system. So we are utilizing in Southwest Virginia, we have 3 hubs, one at Marion, one in Roanoke, and one in Danville. We're utilizing our state hospitals to park cars. When I say hub, it's basically to park a car and have office space for the patient support staff and or supervisors to be present, waiting, and ready to be dispatched. In addition to that, we are identifying hover spots. As you know, and particularly in far Southwest Virginia, Marion is still 3 to 4 hours away from that furthest tip, and we do have some hospitals in Russell County and other places where people will need to be picked up. And so they will be able to hover at CIT assessment centers, hospitals, those kinds of things, in order to be, when they know that there is a potential pickup, they will be able to start the drive and be ready to pick up that patient just as quickly as possible. Safety zones. One of the things we've identified is because patients are being transported so far, there may arise a need for a restroom break or a comfort break for the individual who is being transported. So during these drives, anything over 2 hours, we're considering a longer drive. We will generally have 2 patient support staff in the vehicle with the person that will assist in maintaining custody. But if they do need to stop, we are asking for your help in looking at a safety zone or a spot for them to stop, allow someone to use the restroom. In working with our sheriffs and police officers in Danville, for example, South Boston, is South Boston here today, has agreed to let us use a safety stop there. We really are trying to pinpoint locations where we know there will be frequently traveled routes that they have to go, and we'll probably have to make a stop. So we're asking for your help so that the patient support driver can get the person out of the car, get them to the restroom, and back in an environment in which they can maintain custody. So we will be asking for your help on that. Escape during transport. We are trying to minimize any kind of risk that may happen related to this, but we want to be sure that we have thought about and are addressing all possible scenarios. Code 372833 addresses this for those who may escape. Now, the car is such that the individual in the back seat cannot open the door from the inside, so there is, again, we're trying to minimize that risk. But in the instance that this should happen, in an unlikely event, the way we see it working is that G4S would call dispatch. They would be calling 911 in the jurisdiction in which the person escaped. At that point, G4S can also go to the magistrate locally there where the person escaped and request that a KPS be issued so that the individual, local law enforcement can pick up, hopefully apprehend that individual, and finish the transport to the TDO location. Again, we hope that this is an infrequent event, but we want you to be aware and to know that that is a possibility. Medical or mental health emergencies during transport. Code 372833 really does not address this. We have met regularly with our magistrates around the state, and we are all in agreement the area is gray. It's pretty clear about what happens during escape. It is less clear about when there is a medical or mental health emergency during transport, that the person becomes extremely aggressive or perhaps injured or has perhaps a cardiac condition, a diabetic issue, something like that. So at this point, we would ask that should an event like this happen, that patient support staff would pull over. They would try to de-escalate as best they can. If they can't get to that, they would be calling 911. We would hope that our law enforcement partners would then assist us. We have also engaged state police because we know that they sometimes will be first responders in these situations too. Try to get the situation under control so they can continue on their transport. If it's an injury or an illness to the point that we would require EMT or hospitalization, the patient support driver would then have to go with the individual because technically they still have custody of the individual at that point. They would accompany them to the hospital until that situation was resolved. It's an area in which we may be looking at some more code changes and some specificity around what would happen in this situation, but at this point, this is how we see that working. So who is not a candidate for AT? I will tell you, when we're training our emergency services workers, we are training them with the mentality that everyone is a candidate for alternative transportation unless they meet a certain criteria, meaning they would be ruled out based on initially age. We are going to start this service just for adults, meaning you have to be 18 and over. We will be rolling out the children's piece later on. There are some complexities related to children that we want to ensure we have fully vetted and addressed, and we want to get the infrastructure built and get the adults rolling in during this first year of implementation. Individuals displaying current self-injurious behaviors or things like they have open wounds, they're headbanging, they're trying to strangle themselves, deep wounds from clawing, that kind of thing would need to continue to be done by you all because G4S will not be using restraints. Individuals who are displaying current assaultive or aggressive behaviors. One of the things we've talked a lot with the magistrates about is this idea of active versus passive harm. Someone who is just vocalizing, they feel suicidal, but who would not have the means, doesn't have the means, we consider that passive. That would probably be appropriate for alternative transportation. Individuals at high risk for elopement and individuals who are non-ambulatory, we do ask that the individual be able to transfer themselves, if they're in a wheelchair, from the chair to the vehicle with minimal support. The vehicle can accommodate wheelchairs in the back, but the person does need to be able to at least do the transition. Individuals on oxygen, they can't haul oxygen tanks in these cars, and individuals who are so medically fragile that they're currently transported by ambulance would still continue to be transported in that way. So who is appropriate? Anyone under a temporary detention order at this point can be considered for alternative transportation. So I wanted to give you a couple of examples of individuals. We talked with our CSB pre-screeners, reviewed some cases that they have that they say they would probably recommend alternative transportation for, just to give you an idea of who is appropriate. So in this example, it's a geriatric individual, an 84-year-old male. He was threatening to hit staff with a belt and with an infection from his hand. He attempted to elope from the facility on a couple of occasions and reported that he just really wanted to leave the facility. They assessed that he would be appropriate. Partly his age was a piece of that. I know when I have talked with many of you one-on-one, the transports that are most difficult for you are these elderly individuals and the very young children who are in car seats. So we really hope that most of the time these individuals would be appropriate for alternative transportation. Another example is a 54-year-old male diagnosed with schizophrenia. He'd been living in an ALF for some period of time, quit taking medications, decompensated. He became very paranoid, disorganized in his speech and his thinking. He was refusing to eat and not taking care of his general health needs. The staff at the facility obtained an ECO, had him picked up and taken to the hospital for assessment. A TDO was recommended, and we felt that this is a profile of an individual who would definitely be appropriate for alternative transportation. So there are several areas of challenging, and John's telling me we need to move on, so I just want to make sure that you understand there are several areas that we need your help and we need to communicate well with. Areas of transfer of custody, expiration of the ECO time, and execution of the TDO. The timeliness of those things are going to be very important. During these stakeholder meetings, we deal with that in more depth and work that out. I am so happy to say that in Region 3, we have had incredible collaboration and cooperation around this, and we think it will not be a barrier and that we will be able to do this in order to get the transfer of custody done. We talked about escape and escalation and the need for those safety zones. John, I don't know if you want to have time for questions?
Real quick.
Okay. And I'm going to put my information up here if you have other further concerns. Questions? Okay. He's asking the expected start date in Region 5. So we are looking at a 90-day rollout per region. So we're starting in October in Region 3. We'll be then going to Region 1. Region 2, I think, is next. 5 would be in the spring of next year. Now, I'm saying because we wanted to do this slow, deliberate rollout, we are allowing 90 days between each region. There is some possibility, if it goes pretty well and Chris gets his patient support staff hired more quickly, we will go faster if we can.
Thank you, Gail. We certainly look forward to this program moving forward, so thank you so much. All right, we have a coffee break, and so 10 o'clock sharp, be back. We'll begin, and we'll start with our report from the Department of Forensic Science, and then our awards. You don't want to miss that, so look forward to having you back 10 o'clock. Thank you.